Hello, I'm Soomin Park from Seoul St. Mary's Hospital in Korea. It is a great honor to present our study entitled Missed Incidental Lung Cancer on Next CT, Determinants and Impact on Diagnostic Delay and Stage Shift. Lung cancer remains the most commonly diagnosed cancer and the leading cause of cancer-related mortality worldwide. Its prognosis is highly stage-dependent, which makes early diagnosis and timely treatment essential. In daily practice, radiologists often interpret CT scans that include anatomical regions beyond the clinical question. Next CT is one such example because it often includes the upper lung fields. Since lung cancer commonly arises in the upper lung regions, some lung cancers may be incidentally visible on next CT scans. If these lesions are overlooked, diagnosis and treatment may be delayed. Given these considerations, we conducted our study with the following objectives. First, to assess determinants of missed lung cancers on next CT. Second, to evaluate clinical impact of misdetection, focusing on diagnostic delay and stage shift. Lastly, to explore the potential utility of an AI CAT system for detecting these missed lesions. This was a retrospective study of adult patients who underwent next CT between January 2008 and December 2024. We first identified patients with lung cancer diagnostic codes, then applied the following exclusion criteria, including prior lung cancer, prior or same-day chest CT with suspected lung cancer, and lack of visible lung lesion on next CT. Among the 135 patients remained, 12 with incomplete staging data were excluded, leaving 123 patients in the final cohort. This slide summarizes the definitions of the key variables used in our study. Misdetection was defined as the absence of any mention of the lung cancer lesion in the original report. Double reading was defined as preliminary interpretation by a resident followed by step radiologist review. For diagnostic interval, we used two complementary definitions. The first was the time from next CT to the first chest CT with suspicion of lung cancer, while the second was the time to pathologic confirmation. By this way, we aimed to distinguish radiologic detection delay from downstream clinical processes. Stage shift was defined as progression from the presumed stage at the time of next CT to the final clinical stage at diagnosis involving any T, N, or M category. This included changes in both the numerical category and alphabetical subcategories such as from T1A to T1C. Now I'll present our results. Misdetection of lung cancer lesions on next CT occurred in 80 patients, corresponding to 65.0%. This is a representative case of initially missed lung cancer on next CT. On the initial next CT, a small left upper lobe nodule was visible only on the lung window and was not mentioned in the original report. The patient was diagnosed with lung cancer 68 months later, with stage progression from presumed stage 1A to stage 4A. To identify determinants of misdetection, variables with a p-value less than 0.10 in the initial comparisons were evaluated using univariable and multivariable logistic regression analysis. In univariable analysis, misdetection was associated with CT for head and neck cancer staging, CT angiography, thicker slice thickness, lung window only visibility, peripheral location, and smaller tumor size. Conversely, double reading, lymphadenopathy, lobulated margins, and advanced presumed stage were associated with lower misdetection. In multivariable analysis, CT angiography and squamous cell carcinoma were independent factors associated with misdetection, while double reading, lymphadenopathy, and lobulated margins remained associated with reduced misdetection. Misdetection was associated with a substantially longer diagnostic interval. The median interval from next CT to first chest CT with suspected lung cancer was 17.0 months in the missed group, compared with 0.0 months in the detected group. The median interval to pathologic confirmation was also longer, 27.5 months versus zero point 0.0 months. Stage shift occurred more frequently in the missed group than in the detected group, 47.5% versus 11.6%. Notably, more than half of these stage shifts in the missed group occurred within stage 1. Early to advanced stage upstaging was numerically more frequent in the missed group, although the difference was not statistically significant. Among 80 patients with initially missed lung cancer, AI-CAT detected 41 lesions, resulting in a detection rate of 51.3%. AI-CAT performance did not significantly differ according to slice thickness, mediastinal window visibility, lesion centrality, or lesion size. I will now discuss the possible explanations and clinical implications of our findings. Several determinants may explain increased misdetection. CTs performed for head and neck cancer staging may increase cognitive load, and CT angiography may shift attention toward vascular structures. These factors may reflect the satisfaction of search effect, which could be partly mitigated by checklist-based templates. Thicker slice thickness, visibility only on lung window, peripheral location, and smaller size may also make subtle lung lesions easier to overlook. Careful lung window review with thin section reconstruction may reduce misdetection of small or peripheral lesions, although potential false positives should be considered. Squamous cell carcinoma may be more easily overlooked than adenocarcinoma because it can present with inconspicuous findings such as endobronchial growth. In contrast, several factors appear to help reduce misdetection. Double reading was one such factor, and in the setting of increasing radiologic workload, AI-CAT may serve as a practical support tool. Lymphadenopathy and lobulated margins, both features suggestive of malignancy, were also associated with reduced misdetection. Similarly, advanced stage lesions were more likely to be detected. This slide summarizes the impact of misdetection on diagnostic delay and stage shift. Misdetection was associated with longer diagnostic intervals, both to lung cancer suspicion and to pathologic diagnosis. Stage shift was also more frequent in the missed group, with the majority occurring within stage 1. Although misdetection does not uniformly result in critical disease progression, it may still contribute to stage worsening in a subset of patients, suggesting the importance of early radiologic recognition. AI-CAT identified approximately half of the initially missed lesions. Importantly, its detection rate was not significantly affected by imaging or lesion characteristics that are often challenging for human readers. Therefore, AI-CAT may serve as a supplementary tool by prompting a second look. However, because this analysis included only disease-positive cases, the clinical impact of false positive findings remains unknown, and the overall clinical utility of AI-CAT requires further evaluation. In conclusion, incidental lung cancers on neck CT are rare but frequently overlooked, and misdetection can be partly explained by specific examination and lesion characteristics. Missed cases were associated with longer diagnostic intervals and more frequent stage shift, emphasizing the need for systematic evaluation of the upper lungs during neck CT interpretation. Our exploratory analysis also suggests a potential role for AI-CAT in detecting overlooked lesions, warranting further validation. This is the end of my presentation. Thank you for listening.